Hello, it's Laurie Sullivan here. I'd like to share a recent surgical case with you again where I performed a Dmek triple procedure with cataract removal in a very small eye. The corneal oedema was thought to be secondary to herpetic disc-form keratitis, and there was edematous hazy epithelium that had to be removed initially to enable visualization. There's also a small pupil despite the use of intracameral phenylephrine and topical drops, and here you can see me stretching the pupil. I wasn't really able to easily stretch it large enough to safely do the cataract surgery in this shallow anterior chamber. After refilling the AC with Healon, I've elected to use a malyugin ring, a 6.25mm malyugin ring, to maintain an adequate pupil for cataract surgery. I've loaded it into the introducer and passing it into the AC now, and gently and slowly we'll inject the leading loop to engage the distal iris. Once that's engaged, I'm continuing to inject, really trying to keep a fairly neutral position in the AC. The two secondary loops are coming through now, and the one on the right is just now engaging the pupil, and I'm just angling the device a little bit to the left to get the left one engaged as well. I'm not quite able to engage the proximal iris with the last loop, so I'm electing to leave it in the AC, and we'll position that with a lens manipulator. Once that trailing loop's engaged, I'll just bring the whole device and recenter the pupil. It's quite a dense nucleus, so I'm just going very slowly here, sculpting quite deeply until I'm able to get it cracked. Since I'm planning to replace the endothelium and decimase membrane, I'm able to perform the phaco fairly anterior in this relatively shallow AC. It's quite a high-powered IOL, a 33 diopter Alcon SA60, and it's inserted into a B cartridge. So we need about a 2.75mm wound for that. The cartridge is actually catching on the malyugin ring loop there, so I'm just using a second instrument to press the loop posteriorly so I can get the tip of the cartridge past it. And the lens just goes in as it normally would. Now it's time to remove the malyugin ring. So basically it's a reverse process to the insertion process, disengaging the proximal loop and then the lateral loops, just using a lens manipulator, and then freeing the distal loop finally until the ring is free in the anterior chamber, and then reinserting the inserter, engaging the proximal loop and basically refolding the malyugin ring in the inserter. You can see it's quite soft and pliable, so it's, even though it's not completely folded, it's easy to remove. Here I'm just marking a 7.5mm area for Dmek membrane stripping. Now it's time to prepare the graft, and I'm just putting a little bit of vision blue on to stain the edges of the graft and a bit of BSS. I'm just going to make sure that the graft is sitting flat against the stroma and not displaced or folded, as can sometimes occur. And you can see I'm just wecking away the fluid there from the endothelial surface with a sponge. And it seems to be in perfect position. Now I've turned the graft over, and I'm just going to remove the small punched out stromal window that the eye bank had previously prepared in preparation for stamping the stromal side of the graft with an ink stamp to indicate the anterior surface. The first stamp was a little bit wet, and I've just re-dried that surface, and you can see a nice S or 5 stamp there. Just replacing the plug. Now getting ready to punch the graft from the endothelial side, just centering it there so that I get a nice nice area of graft. I am using the vacuum, low vacuum, to hold the graft steady, and just tapping in 4 quadrants. So we really only need to punch through Dmek. We don't really need to punch the stroma too much. Carefully lifting off the punch and making sure that the graft is where I expect it to be. Filling the well with BSS now, and peeling off the peripheral Dmek membrane, leaving the graft centrally. Looks like, yes. And now staining it with vision blue, just to make the graft edges more visible. Just starting to peel at the edge of the graft now with some curved tying forceps. Being very careful to watch both sides as they come. It does look a little bit adherent above and to the left there. Just refilling with some BSS. It makes it easy to see once you dilute the vision blue. And just picking up that edge again and continuing the tear. It's a little bit adherent there, so I'm going to pull the other way, just like a capsular rhexis, and there's a little bit of an extra tag there. restaining the graft with Vision Blue now, and we'll leave that for 5 or 10 minutes while we prepare the host. Just performing a peripheral iridotomy with some Van Ness scissors. The preoperative one that was done with the laser I wasn't sure it was patent, and I did inspect it but couldn't be certain it was patent now, so I thought I'd do a surgical PI. And just now starting to score the Desime's membrane along my marks with a reverse Sinski hook. Continuing now to strip Desime's carefully, trying not to leave any tags. This Desime's is fairly thick, and it is fragmenting a little bit at the edges. I am trying to engage the Desime's membrane here without scoring the underlying stroma, and I've finally managed to bring it out through that paracentesis. You can see how thick and fibrotic it is just from its behaviour here. Patient's moving now. She's just woken up. Just having a look at the membrane to see how complete or otherwise it is. I will go back in and stain the residual Desime's inside the eye later on. It's just nice to have a look at what we've got to start with. Just a bit of stain on it there now. Now performing irrigation aspiration to remove the cohesive viscoelastic. I just used normal Helon for this case. Irrigating behind the pupil and also behind the IOL in a moment. Here you see me just displacing the IOL and getting the irrigation and aspiration behind there to clear the viscoelastic from the capsular bag. Just grasping that distal fragment and then the proximal fragment just inside the wound there. Alright, time to look at the graft. Just aspirating that into the goiter injector, connecting that to the BSS filled syringe. and preparing to inject that into the anterior chamber. I'll direct the graft away from the pupil so it doesn't go behind the iris, and make sure that the AC is fairly shallow at this stage, and even help to shallow it a bit as I'm removing the injector there. Next thing, we need to get a suture in to make the chamber watertight. I'm using a slip knot here so that I can adjust the tension whilst I'm tying the knot. Now with two syringes with BSS and Rycroft cannulas, I'm going to nudge and try to position the graft into place. I'm trying to visualize the S to make sure it has its stromal side anterior, and you'll see I periodically shallow and deepen the AC as needed. The graft, compared to the tissue that was removed, is much thinner and floppier. Doesn't really want to scroll. Once I've got it into approximate position, I'm going underneath now with a syringe with air and just injecting a bubble to better see the conformation of the graft and where the edges are. And I'm using that bubble just to push the edges out where indicated there. And just letting some fluid out as well to try and help that graft unfold in that area. With a fuller airfill, I can see now that the lower left edge of the graft here is folded on itself. So I'm going to need to fix that. And I'll take some air out and put some balanced salt in and try to get that edge of the graft to unfold properly. The bubble's still too large and I have to remove more air before I can get that graft edge freed. So injecting some BSS and taking out air and just trying to use the jets of BSS to just make that graft edge float again. There we go, it moved. And with tapping, it's tending to unfold with a little bit of help from the bubble underneath it as well. You can see the graft edges moving with the fluid flows there. There we go, it's finally unfolded nicely. Going back in with cannula, shallowing the AC again. That encourages the graft edges to flow towards where the egress of fluid's occurring. And here's another air bubble, and I can see now that the edges of the graft seem to be well positioned. Just removing the air bubble there, because I'm going to replace it with SF6 sulfur hexafluoride 20%, which should stay in the eye for 4 to 5 days at least. Just hydrating the wounds now and making sure the eye can hold pressure. And I'll then check the wounds with fluorescein. And there is a leak, so I'll suture that. And finally, a bandaged contact lens to protect the ocular surface. It will be. Here we see a day 4 post-op slit lamp photograph with about a 40% AC gas fill still, and on higher magnification we can actually see the edge of the graft above and to the right there, and we can see that it's well attached. Thanks for your attention.